Hello and welcome everyone. My name is Jennifer Zellmer. I'm the CEO of Healthcare Excellence Canada, and I've got a few housekeeping announcements to make before we dive into today's webinar. So first of all, please note that this session is being recorded so that you can refer to it afterwards if you wish, but so that others who weren't able to be here right at this point can actually access the information afterwards. As you may have seen just popping up in the chat, we're pleased to offer French simultaneous interpretation for this session. Si vous veuillez entendre la session en français, appuyez sur le bouton au bas de votre écran. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. And if you need support at any time during this webinar, you can reach out to our tech support using the chat feature. English participants may choose to view the auto-generated live transcripts or subtitles throughout today's session by clicking the CC Live Transcript button from the Zoom menu, again at the bottom of your screen. French subtitles unfortunately cannot be viewed live, but we're pleased to make both English and French captions available on the session recordings. As I said at the beginning, my name is Jennifer Zellmer. For those of you who've just joined, we see the numbers climbing as people are flipping into the session, and I'm so pleased to be your host today. As you may know, Healthcare Excellence Canada is a new organization launched in 2021, and we aim to have a relentless focus on improving healthcare with and for everyone in Canada. As we begin today, I would like to start by acknowledging that I'm joining from traditional unceded Algonquin territory, near the place where the Ottawa and Rideau rivers meet. And as I've been learning more about this place where I'm so fortunate to be able to live, work, and play, I've learned that this is an area that has been a place of meeting, a place of connection, a place of conversation and exchange for millennia. And so hopefully through this virtual mechanism today on today's webinar, we can continue this tradition, but in a new technological format. Our Spotlight series is an opportunity to have focused constructive conversations and to explore solutions, how we can together make improvements that last as we work together to shape the future of quality and safety in healthcare across the country. Our focus today is safe to say, learning from patient safety incidents to create safer care for everyone involved. When avoidable harm occurs in healthcare, there's a risk of blaming and shaming and a risk of further harm. And that can include a culture of fear that really discourages transparency. So today, we'll hear about experiences of patients, of loved ones, of healthcare providers, of those involved in organizing systems for safety and quality, to better understand factors that contribute to, in this case, medication safety incidents, given that we're just coming up on World Patient Safety Day, which in this year is focused on medication safety. And also an opportunity to discuss what's needed to create better, safer care for everyone involved, and a safe to say culture that encourages understanding what happened and how we can prevent future harm. We invite you at any questions and comments in either in English or in French in the chat box, and I'll do our best to get to them all as we have today's conversation. As we jump into the webinar, I also want to recognize that some of the topics that we're addressing today may be difficult. And we want to set up an environment that's as psychologically safe as possible. So you'll see that we're adding some mental health resources into the chat. Keep them around. You or someone you know may be struggling, and it's always easy to reach out when you've got some connection points for where to go. So without further ado, as I introduce today's speakers, I'd invite you, all of you on the line, to jump into the chat, introduce yourselves so we all know who's on the call and can broaden our community, and welcome you to provide land acknowledgement in the chat as well if you feel comfortable doing so. So joining us today, beginning on the left of my screen, hopefully everybody's got the same order of the screens, but on the left of my screen is Deb Prowse. I've been so fortunate to be able to get to know and work with Deb as a member of Patients for Patient Safety Canada. She's also a daughter of one of two people who died in 2004 and that journey described in a new book called Fatal Solutions: How a Healthcare System Used Tragedy to Transform Itself and Redefine Just Culture. And on her right, so in the middle of my screen, is Ward Flemons, who is an author of that book and also professor in the Department of Medicine at the University of Calgary School of Medicine, and a long-standing person who cares deeply about patient safety and how to improve safety. And last but certainly not least, Wendy Nicklin, who has had many hats over the course of her life and career, is joining us today as co-chair of the Healing After Harm Working Group of Patients for Patient Safety Canada. So a big welcome to all three of our panelists today, and a huge thank you for joining us for today's conversation. So we're going to invite each of our panelists to begin with an opening to tell us a little bit more about them and their connection to the topic that we're speaking about today. So Deb, I'm wondering if I can start with you, because this story really begins with you and your family. Oh, and you're just on mute, Deb.
So honored to be here today. So thank you very much for inviting me. I'm here on two aspects of a story. One is related to my mom, and I'll give a high level overview of my mom's story. And the other is my story as a patient safety advocate. So let me take you through a little bit of the learnings and insights that came out of an incident that occurred, seems like a long time ago now, 2004. My mother entered her 80s as a fierce and independent, vital woman who took care of herself and her home, was active in community and with her family. She was a retired nurse, and she approached healthcare cautiously. She knew that patient safety was an important aspect of care. When she had a hip replacement surgery, she opted for an epidural, so she would be awake to correct the surgeon if he made any mistakes during the surgery. And unfortunately, there were a number of events that followed her hip replacement surgery that led to her death. Immediately after her surgery, within 24 hours of her hip surgery, she went into shock and had a heart attack in the ward. This failure to rescue was despite medically trained family members, 2 doctors in our family, that were at bedside requesting that she be assessed and have a response because they could identify her deteriorating condition. There was no rapid response process at that time. After hours of trying to get a response from nurses or a doctor to attend, she ended up having a heart attack, and the family was in the process of desperately trying to get her help, with a plan to use the staff elevator to take her down to the emergency room so fresh eyes could assess her and save her. A surgeon arrived finally, and his first reaction was to address the family members, and he actually threatened to have us criminally charged with causing a disturbance because we had upset the nurses. After advising us of this, he went in to assess Mom and saw that she was dying. Mom had lost so much blood at that time that my niece, a doctor, was asked to handbag blood into her, and she handbagged 11 bags in. She spent 12 days in ICU to recover from the heart attack, and then she had the recovery from the hip surgery as well. We heard nothing from the hospital about what happened. There was no acknowledgement to us that anything had happened. In fact, all of our attempts to contact people, talk to people, all of our overtures were firmly rebuffed. Mom recovered over the next many months. We are a legal family. My father was a Court of King's Bench justice. My sister and I sat in court as well. And we asked Mom, do you want us to take legal action? And she said, no, I'm getting old. I'm going to need medical care. I don't want there to be a black mark against my name. 13 months later, her damaged heart developed endocarditis, and her tragedy continued. 24 hours after heart surgery, she bled out again. Family members raised the concern about her deterioration, but nothing was done until she finally coded and had to be returned for secondary surgery. She had bled out again. This time, however, her kidneys did not recover from the code. She needed dialysis, which sealed her fate. Unbeknownst to anybody, in the prior weeks, 35 bags of dialysate solution were made in the central pharmacy of the hospital. They were made in a check system with a checklist that was produced by the system to follow. The bags were made and held for ICU use. When Mom was having her heart surgery, another patient in another ICU needed dialysate. He died unexpectedly, and nobody looked into his high potassium level at that time. On the Friday morning after Mom's surgery, on March 5th, 2004, Mom received her second bag of dialysate, and she coded. Her potassium level was 9.8. They could not revive her. Subsequently, it was learned about the 35 bags of dialysate that had been made with potassium chloride instead of sodium chloride. And that was the start of my journey into the patient safety advocacy. One of my champions on my journey, and I can speak later about that journey, one of the champions was Ward Flemons, and I will turn it over to Ward to continue the story.
Thanks very much, Deb, and welcome everyone. And thanks very much, Jennifer, for organizing this and hosting it. As Deb said, my name's Ward Flemons. At the time of Deb's mother's tragedy in the Calgary Health Region, I was leading a relatively new quality division within the health region. So my official title was Medical Director of Quality Improvement and Health Information for the Calgary Health Region, which at the time I think was the largest integrated health region in the country. When we learned about first Deb's mother's death and then traced back and learned about the other patient, it was a devastating finding. Everybody was in shock, and there was no game plan for how to deal with that because the organization didn't have a history of dealing with patients in an upfront way. They didn't really have an approach. It was the days before disclosure was required, and most people didn't know about disclosure, didn't think about disclosure, and still in the mindset of if you open your mouth and say something, you're likely going to introduce the chances for a lawsuit. So people tended to remain quiet. We learned a lot from trying to do the right thing as guided by some information we'd acquired or had been studying from people like James Reason. We were very fortunate to have a patient safety expert in our midst, Jan Davies, who was one of my co-authors of the book. And through a variety of different approaches, we decided that we would take a different approach to this terrible tragedy that Deb and her family and the other patient and his family had gone through. So rather than just make a few changes and say everything is fixed, we basically tried to strip down the system and around culture. So we became very interested in the concept of James Reason's just culture and how that fed into a safety culture. And that's really about transparency, trust, openness, and encouraging people to come forward and report what they see as wrong so we can fix it before tragedies like this happen, but also to respond in the right way when tragedy does happen so that patients don't get harmed a second time. And that was about a 3 to 4 year journey until the Calgary Health Region got turned into Alberta Health Services. But we learned so much at the time, thanks to people like Deb. And I hope Deb has a chance to tell a little bit more about her transformation, but also how she helped to transform us. And also our CEO at the time, Jack Davis, who through a lot of humility was able to say we can do things different, and allowed us to do some of the changes that we thought were so important in order to really fundamentally get a safer culture within the Calgary Health Region. And with that, I'll turn things over to Wendy Nicklin.
Yeah, thank you very much, Ward. Good morning and good afternoon to everyone. My name is Wendy Nicklin, And while I have a long history of working in healthcare with a focus and commitment to improve quality and safety, I'm participating on this panel, as Jennifer mentioned, as a member of Patients for Patient Safety Canada. I joined Patients for Patient Safety Canada approximately 2 years ago. Shortly after joining, quite soon after joining, I was asked to co-chair the Healing After Harm Working Group with Dale Nixon of Newfoundland Labrador, with the goal of developing a healing program. It is now called the Mutual Healing Program, and I look forward to sharing more detail about this with you during this interview. I must say at the outset that Healthcare Excellence Canada is strongly supporting our Healing After Harm work and the Mutual Healing Program through the provision of resources, human and financial, to which we're very appreciative, and explicitly noting this initiative within the strategic and operational plans. So thank you to HEC. All members of Patients for Patient Safety Canada directly experienced harm in the healthcare system. My sister-in-law had open heart surgery in 2010 at the age of 61 and woke up paraplegic. It was a tragedy, and we together experienced an absence of transparency, an absence of disclosure, an absence of support for Anna, my sister-in-law, and our family. And yes, we ended up in court to try and get some answers. My husband, who's a cardiac anesthesiologist, and I walked through every step of the way with my brother and Anna. Rather than cardiac rehab post-surgery, Anna was discharged to spinal cord rehab and lived there for over a year. They had to sell their home because it was not suitable to be adapted for a wheelchair. The rest is history. Sadly, we never got answers, and in fact, lost the lawsuit, leaving my brother and Anna in debt, financially and psychologically. I knew that her story must be told and the lessons learned. Although encouraged, Anna personally did not have the energy to join Patients for Patient Safety Canada. However, I said to Anna, do you mind if I join then in order to share your story, our story, and enlighten others to the lessons learned? Sadly, Anna died in April of this year at the age of 73. Aspects of the book Fatal Solution relate to our story as well. Although sadly, the culture of this hospital in Montreal, a teaching hospital, did not focus on quality and safety, was not transparent, and the psychological pain endured by Anna and ourselves, which could have been lessened and enabled healing, remained for years and years. Ironically, Anna accepted her reality and gradually lost her anger after about 3 to 4 years. I must admit that personally, my anger persisted long after that. Learning from patient stories about adverse events is powerful and vividly paints the picture of what went well, what went wrong, how to heal and move forward, or not heal and continue to feel the psychological pain. I look forward to this session with Deb and Ward. Thank you for being here.
Thanks so much, Wendy, and thanks, Deb and Ward, as well, for setting the table for our conversation today. And I'm wondering, Deb, if I can turn back to you to sort of pick up where you left off, as Ward suggested you might. You shared in your afterword of the book that we're in this together when adverse events occur. So I wonder if you would mind sharing a little bit of that, what came next and your journey to being a patient advocate.
It started with courage and listening, and Jack Davis needs to be given credit for that. He had the option of how to deal with the situation in which 2 patients had died under his watch, and he chose courageously to start listening to patients. My path took about a year after Mom died, and until I was at a place that I could even imagine becoming involved with the healthcare system because of the anger and the grief that I was going through. But Jack persisted in wanting to listen to patients, and he made the 2005 Healthcare Symposium, Halifax 5, about patients and listening to patients. And he, against the lawyer's advice, I think every lawyer in Calgary probably sucked air in when he said, I'm going to bring a whole bunch of patients to talk about harm, to make it public. But he persisted and he did it. And I was in the reception after patients had told their story, and the room was just vibrating with emotion. Jim Conway had come up, and Jim was talking to Jack, and Jim said, so what are you going to do now? Now that you've listened, what are you going to do? And he just kind of off the cuff said, well, I'm going to bring them together in this group. And I overheard that. I was standing kind of behind them, and I overheard that, and I thought, oh, I'm going to be part of that group. So when I was invited by someone to join the group, I signed up right away. And from that point, I tried to leverage the story, the experience, the learning in every way I could. And I was known as a founding member because I was founding member of the Calgary group. I was founding member of the Patients for Patient Safety group. I was founding member of the Health Quality Council group, and founding originally of invited to be in the Alberta Health Services group. But it was making those connections and keeping the story. And initially it was very much, oh, we've written a document, would you edit it? It was, we needed a patient to be part of this group, could you attend? It was very cursory, superficial. It was the invitations weren't always genuine. They were to tick off the box that we have a patient. But I've been able to see over time how patients have been able to integrate the policy decision rooms, the tables where decisions are being made. And I always heard that having a patient present really changed the conversation. And I think that was about the listening, the empathy, the learning, because patients have so much learning to bring to the table. Whether it's the family members or survivor of a harm incident, they have information that is necessary to that investigation, or whether it is about how a policy is going to impact people on the pointy end. And so I for years, Ward could probably attest to this, I did not say no to anything I was invited to. I wanted to speak at and the health system, putting a patient up for the first time and not knowing what's coming out of their mouth is pretty scary for the health system. But Ward was there as a leader champion. And one of the things that I think is really important is that there are champions. There need to be champions inside the system. There need to be patient champions. There need to be other organizations, because Wendy was one of my champions as well. She was at CPSI and then at ISPA, and she's always been one of my champions, my go-to that I know I could call. And it's so important that that we make those connections and that people lift other people up into this work. So my goal way back was I want to speak at an organization like ISQA, and last year I was able to do that. Last summer at their conference, I was able to do that. So it was a journey. My patient safety advocacy journey was about getting connected, bringing the story out, and then the book that Ward and Carmela and Jan Davies have written really puts it in a framework that I think is so current and so necessary, and gives some insights for organizations going forward.
Deb, you're making my job incredibly easy also, because you've just given a perfect segue over to Ward. So thank you for that. And Ward, particularly, you wrote the book, and that book reflects a journey of experiences towards a just culture. Can you talk a little bit more about what that looked like in practice, and how you see things today?
Yeah, well, it's hard to believe that it's, as Deb said, 17 years ago, 18 years ago. I think first of all, we didn't quite believe it when it happened. And then once the reality set in and we started thinking about changing, you can take a tactical approach to changing a few policies here or there, or you can take more of a cultural approach and say, we've got to change people's attitudes and the way they approach this. In my experience, people in healthcare are scared stiff of patients, especially patients who've been harmed. And or their families of the patients did not survive. And so it gets, there is no conversation, there's no information sharing. And that was one of the attributes of Jack, is he was able to go cut through that. We were able to put some policies in place that drove a culture. So we put a just culture policy in place. So we wanted people to start being more open with things that they saw wrong. We wanted to start relating to other patients like we learned how to relate to Deb. So we put a disclosure policy in place long before disclosure was the thing that was required to do, and very glad that it has now become a standard of practice. It was long overdue. But, the amazing thing was to see that healing was possible if you provided the opportunity for people to talk to one another. And traditionally, and still, I still see it, patients or families who've been harmed and the providers that have been involved don't talk to one another. They're not allowed to talk to one another many times. The organization doesn't do a great job of talking to patients. And the remarkable thing with Deb, it took a long time and it was not really programmed, but we were able to connect her with our director of pharmacy, who felt very responsible for what happened to Deb and the other patient that died, Deb's mother and the other patient who died. It never left him for the rest of his life. And he was also an amazing individual. When those two got to meet and actually share their own journeys and their own stories, it was an amazing process of allowing them both to do some additional healing. And Deb can probably tell the story much better than I, but what we were able to do is to figure out that it's all about healing at the end of the day, and not to harm patients a second time. And we really learned a lot about how most patients and families, unfortunately, are harmed a second time. And Wendy's story is a perfect example of that. You have to be able to talk to patients and their families. They deserve an explanation. They deserve an apology. They deserve to hear how things are going to change. And the remarkable thing about Deb and so many other patients is, at the end of the day, that's probably the most important thing for them, is to know that their negative experience isn't in vain, that something positive is going to come out of it, and other people are not going to have to go through what they went through. We have to give them that opportunity.
Thanks so much, Ward. And I will turn back, Deb, to you in case you wanted to elaborate, as Ward suggested. As we do so, though, I just wanted to acknowledge that there are comments also starting to come into the chat that very much reflect what you just said, Ward, about, the opportunity to pave the path a bit smoother for others is now what we do. So I invite everyone who's on the line to add your comments and reflections, questions to the chat as well, and we will do our best to weave those through. But Deb, I'll open the door to see if you wanted to add, and then Wendy, I'm going to be coming to you next, just to warn you.
So let me go back to the meeting with Steve. Steve Long was the director of pharmacy, and he had, in his view, created the safest pharmacy in Canada. He was a man that was absolutely committed to patient safety. But in the creation of that checklist, the substance that you're holding was not on the checklist for those pharmacy techs to check. They had everything else. They had box numbers, lot numbers, everything else, but they didn't have what is the substance you're holding. And that was a miss that he never forgave himself for. And it took 2 years. He was working on some things in patient safety. I was working on some things in patient safety. In the Calgary Health region, we didn't run into each other. And finally, a woman, Sharon Middleton, who was working between the two of us, said, hey, do you guys want to meet? And we did. And it was an incredibly emotional, healing conversation. 2 years after that, Steve and I presented on harm to healing, how providers and patients need to heal together. And a woman was crying in front of me at the end of the presentation. And I said, "I'm so sorry for making you cry." And she said, "I'm the pharmacy tech that made the dialysate." And it was incredibly crushing for both of us to stand there with each other, arms wrapped around each other, sobbing. And then Steve facilitated an opportunity to meet with her and her husband after that as well. That's when the true healing was. But the advice and the practice was, don't put them together. So Ward and in his work and my work has been very focused around put the people together and allow them to go through the process of sharing what they've each experienced. And you'll be amazed at how often they will describe the same emotions, the fear, the frustration, the shame, whatever it is. There will likely be overlaps of what people are feeling and how they can heal together through the conversations that they have. What we developed was the 3 A's of disclosure, is the acknowledging that something happened. It's critical that it's not denied, lied, demand proof on. It's acknowledge something has happened, apologize for what needs to be apologized for, and action to prevent it from happening again. And those are fundamental keys of how to do good disclosure. And so very important. And I'm thrilled that Wendy is taking the harm to healing work forward from this point. So it's great to have that program with HEC going forward.
And Wendy, I think that is your open door.
I think so.
Mutual healing, over to you.
Thank you very much. You wonder how much of this is serendipitous and how much the time has finally arrived, although too bad so long, but that we are here. Several things have come together. First of all, within Patients for Patient Safety, the members who have all experienced harm, such as myself, Deb, others, we're already discussing how can we deal with healing after harm. So the issue of healing after harm was recognized by the members as something that needed to be embraced, and how would we approach it? At the same time, Dr. Diane Aubin was beginning her PhD research, and it's Deb's story, her story of healing, that inspired Diane to pursue her PhD research in this area. So we had the Healing After Harm working group that I'm co-chairing with Dale, thinking about healing after harm. Could we develop a program to enable, facilitate healing after harm for both the patient and family and the healthcare workers? And how might we move in that direction? And we initially started a bit down the restorative justice, restorative approach highway. But then Diane's research presented itself. And Diane's research showed that both patients and healthcare workers have great empathy for each other. And many participants felt they would have had a better chance to heal sooner if they'd met each other. And important to note that the Mutual Healing Program, and I can elaborate, pardon me, as you wish, it's not a standalone. So it's not, here's a template, here's the fix. It would need to be integrated with the existing incident management processes and accompanied by strong psychological and emotional support programs for both patients and healthcare workers. So while we're putting a framework together and what some of those ingredients and pieces are and criteria for where it might be applied, it needs to be aligned with the organization within which it would be applied. And I'll say very quickly now, the program has not rolled out yet. We're in the process of identifying some demonstration sites, some hospitals that would be prepared to do a demonstration project for us, with us working with them in guidance, and do it in several different organizations and do a full evaluation, and then be able to improve it and be able then strengthen it to roll it out and offer it further. But I think it goes back to Deb's story being a trigger for Diane's research, simultaneous with the Healing After Harm focus of the Patients for Patient Safety Canada, the working group. And they've come together beautifully, and we're moving forward in a very, I think, progressive and positive step.
Thanks so much for sharing that, Wendy. And I've been following a number of comments in the chat, and I'm going to try and bring a few together, Ward, to ask my next question of you. Several people in different ways have talked about the importance of courage. Courage to speak, but also courage to listen, courage to act in this environment. I'm wondering if you can talk a little bit about what were some of the dynamics that made it possible. You've spoken a little bit about Jack's role and others for the Calgary Health Region to really make that decision for a fundamental culture change and moving towards that acknowledgement of situations as they existed, and then the responsibility of making change in a different way.
Yeah, thanks for the question, Jennifer. Tough to answer. I think it helped to have a blend of leaders that were not reactionary and weren't going to make split-second decisions, even though there was a lot of pressure on them to, quote, do something, and by that people meant who's going to be fired. So that was really helpful because we didn't fire anybody. Nobody lost their job. And that was a really important statement to the organization and to everybody else. It took an understanding family and family member like Deb to not to demand, quote unquote, justice. And in fact, Deb very early on was saying, we are worried about the techs that were actually involved. How are they doing? So that there's a big piece of humanity there that isn't open to everybody, but that made a big difference. We had the safety expert. I mentioned my colleague Jan Davies, and fortuitously at the same time we were also starting to host the Healthcare Series, Canadian Patient Healthcare Safety Series, which Deb referred to. We called it the Halifax Series because it started in Halifax for the first 3 years. And as it turned out, that year, Jan had offered to take the series over from the organizer in Halifax, and we tried to envision this idea of transparency. And we had invited a patient to come at Halifax 4 to tell their own story of harm in the Alberta healthcare system. It wasn't in Calgary, and this program was being offered in Edmonton that year, and then it was going to be in Calgary the next year. We got shut down 2 weeks before the conference and said you can't have a patient tell their story live. And so we were shocked at that. And I was working on this with Jan and a few others, and so we tried again in Calgary the year after. And we specifically went to Jack and said, we expect some interference from high up. Will you run interference, or will you run interference for us? And we were right. We got it, and Jack ran the interference. And so we had 1,000 people in the Westin ballroom in Calgary, downtown Calgary, listening to patient stories and taking a lot of heat for it. So it was that spirit of the only thing that's going to make a difference here is to talk and transparency, and not run away because you're afraid. And Jack listened to Jim Conway, who at the time was senior fellow for the Institute of Healthcare Improvement, but it also guided the Dana-Farber Cancer Institute through their own tragedy back in '94. And Jim's comment was, lawyers need to have a vote at the table, not the vote at the table. And Jack actually listened to that, and that made a difference. Not that lawyers are bad, they've got great opinions, but when it's the only opinion, then sometimes you don't do the right thing. So there needs to be a good blend of that, and the leader strong enough to say, I'm going to do what I think is right, and might go offside with a few people. In fact, could go offside with a lot of people, but if you're treating the patients right, it's the right thing to do.
Thanks so much for those reflections, Ward. And, there's been some other reflections in the chat as well. And Deb, I wonder if this is one you might want to come in on, given your experiences, about the importance of it being safe to have conversations at that moment in the course of care, and also after harm has occurred, and any reflections you might have on that sort of continuum of conversations where it needs to be safe to say.
disclosure, having really good disclosure and having healing after adverse events starts way before anything goes wrong. And it is setting the stage of communicating, engaging with patients. And that allows, if things go wrong, to have at least a core relationship to then support going through difficult times. So we often I've helped do disclosure training. It is about setting the stage for that, being transparent, being open, getting proper consents, but having that openness of conversation and being transparent about things. Because when things go wrong, that's what you want to go back to. And that will help in the more difficult times. So I think that that's really important, that it starts way before anything goes wrong.
Thanks so much for those reflections, Deb. And that's in every moment, every day, isn't it?
Yeah.
That ends up being so important.
Yeah.
Yeah.
It's having that full, wholesome patient engagement. That and everyone in the health system has to have that proper engagement. From the lawnskeeper to the surgeons, you need to have that. Recognize that every patient needs engagement to go through the journey they're going through. You're privileged to go on that journey with them. They shouldn't be seen as a bother, a pain, a difficult person. We were labeled difficult people. We were treated as difficult people, and I unfortunately, we're not the only ones. I've interacted with many patients that had difficult labels, difficult patient, difficult family members that have been banned from facilities, that have been physically removed from facilities simply because they were trying to advocate. And in the majority of the situations I have dealt with, they were advocating with cause. There was reason for them to be advocating.
Yeah, I think that's such an important point, Deb, because I think that also creates a culture of fear where people may not speak up because they're worried about being labeled difficult or how that might affect a care relationship.
We hear that all the time. We hear that patients are afraid to ask a question or to speak up because I don't want to be labeled. And that should never happen. It should. And I've had situations where nursing staff in ER have called security because the patient is becoming difficult asking questions. And security has quite frankly said, here's my card. You'll need a witness for how you've been treated. And, that just breaks my heart that we can, sometimes during your workday, you forget that you're there with a patient safety lens on.
Yeah. Thanks for those reflections. Wendy, I'm wondering if I can turn to you next with a question that's come in because of your experience in the Healing After Harm group more broadly. The question is reflecting on, theme in the comments about the importance of getting those involved together when harm occurs. And a question about, is it essential that it's the actual individuals who were involved in the incident? Or, sometimes, maybe often, it's the organizational representatives who meet with patients and families, or if time has passed or employees have moved on. Are there effective ways when maybe it's not possible for whatever reason for those directly involved to get together?
That's a very good question, and there's no magic bullet here. I think it depends on the situation, the context, the organization. I think sometimes in some organizations, and we're learning this as we work on this program, in some cases, it's not the healthcare worker directly involved in the adverse event, but it might be the chief or the manager or director who comes in and speaks about what happened and discloses, etc. But the actual care provider who was directly there at the point of care isn't necessarily the person who does that, has that dialogue. Our intent would be to bring those closest to the point of care together. So to have the chief or manager or CEO there, that would not be the intent. The intent really is to get those closest, those who have been psychologically harmed by the event, and who would be, and the patient family, and who are willing, both need to be willing partners, who are willing to come together. Now, one of the challenges is to develop the criteria by which, is this the right situation in which to do this? And so that's part of what we're discussing, and with Diane's support is, what are the situations in which, we have a situation in which that mutual healing discussion needs to occur, because we expect that disclosure has already happened. We expect that other steps in the process have already occurred. This is another step to then be enabling the healing. So there's no magic to this, but it needs to be closer to those who have been psychologically affected by the incident, and then identifying that. And the other point I would just make, Jen, is that we need to, with the organization, identify, are we in an organization which has a just culture? Are we in an organization where openness and transparency and recognition of patient safety incidents are talked about and it's open? And how do you define that? I mean, we can have words. Oh, sure, it's transparent. Oh, yes, it's open. But you and I, we've all been in situations where we think, no, it's not safe to talk here. Or the employees would say, so-and-so can say it's an open, transparent organization. But let me tell you something, my manager, if I said whatever, would make this difficult. So I think we all need to self-examine our units, self-examine our organization, and do we actually have a culture that's going to be receptive to then enabling the mutual healing to occur? But again, who the players are closer to the actual point of care would be the intent.
Thanks so much, Wendy. And I think, Deb, you want to jump in on this too. And there was also a question directly for you in the chat. So maybe I'll let you weave both in together, which was around the timing of disclosure. And if disclosure happens immediately after an event, some things may not be known at that point. So your recommendations on timing too. So over to you.
So disclosure isn't a one-off conversation. Disclosure is a process over time. And poor Ward can tell you 5 years after mom died, I think it was, no, maybe it was 5 years after the first incident. So 4 years after she died, he facilitated a mediation between me and the surgeon that had threatened to charge us with criminal charges. That was an aspect of our experience. Who he was speaking to at the time was one of his colleagues who was a physician, my sister who was a family court judge, and I was a traffic court judge at the time, and he was threatening us with criminal action. That was devastating. It was absolutely devastating. And I didn't get over it for a long time. And Ward made the opportunity for me to meet with that doctor and have a conversation. And it's gone. It's put behind me. That it literally, in that conversation, changed my life. It changed going forward. So disclosure isn't ever a one-off. So the disclosure should start right after an incident with just the information. We don't know everything yet. We'll come back to you and keep talking to you over time. But we wanted to reach out and have this conversation now and start it. And then have liaisons that are involved in it over the period of time. But what I wanted to say was that time frame isn't, to me, it's not just one conversation, it's several conversations. And it may be a roundtable discussion, or it may be a mediation. And one of the best examples of a mediation was a surgeon, busy ER, has a 24-year-old young man with needs an appendectomy. He does the surgery. He opens the abdomen with the wrong trocar. He uses a trocar that has a blade on it, and the blade severs through the abdomen, and the boy dies on the surgical table. And he has to go out and deal with the father. it took 2 years to put the two of them together in mediation, and it only happened because there were people advocating me for the family, and a lawyer representing the surgeon who said they both have a right to meet. They both have a need to meet. And they went into a mediation. 3 hours later, they came out, and the father everybody was sobbing, but the father said, we cried together, we learned things we didn't know, and we are now friends. And what more healing do you want from healthcare? That's the way it should be. That should be our gold standard of where we want conversations to go.
That sounds like an incredibly powerful moment for them individually, but also for all of us in order to be able to learn from. And, you know, Ward, I wonder if this is maybe where I ask you to jump in again in terms of, you know, how do you build that muscle as a system? There's been several reflections in the chat about situations where, you know, it didn't feel safe to speak up, and creating that culture across a giant organization as Calgary Health Region was at the time, AHS even bigger now. How do we do that?
Well, I think it really depends on the type of leadership you have and what messages they send. And it's not maybe just the leader, at the very top, but there has to be a culture at the top, which is we may not get it right all the time, but we are going to talk, and we are going to listen, and we're going to listen to everybody, not just the people that report to us. So we're going to listen to patients and families. We're going to tell patients stories. So, you know, one of the recommendations from the IHI that we started doing in Calgary, which is all the board meetings, they would tell us a story of things that did not go well. And you get people to say, okay, around here, it's okay to talk about things that don't go well. It's not the only thing we talk about. There's lots of things that go really great. But if something doesn't go well, we will talk about it. And that starts to affect culture because it changes the way people think, and it changes attitude. And so it's not an overnight thing, but it has to be very determined. It has to be thought out, and people have to commit to it. So it can't be, as Deb said, just a checkbox. Got a patient in the meeting, check. So again, I think it takes courage. And I hate to say it's not just all on a CEO or a healthcare leader. It also depends, I think, a big time on our political system. Because like it or not, and I don't like it, but our healthcare system in Canada tends to be way too politicized, and the politicians are way too close to the healthcare system, in my opinion. So it's very hard even for CEOs and their senior leadership team to do the right thing all the time, because they're looking over their shoulder. So we need to have a big rethink and say, what is the healthcare system for? We can't always get it right. We don't always get it right, but we can always respond in the right way if we just get the culture better. So leadership's really important, and understanding. So and I really, really appreciate what Deb and Wendy have been saying about getting people together. I think we have to be a bit careful about that as well, though, because that has to be mediated really well. So we've got to invest in that kind of skill set, because if you don't get it done the right way, it actually makes it worse. So lots of opportunities to build skill sets around supporting patients, supporting healthcare providers who are also very harmed by these events, and we can do better things for both of them with this kind of an approach.
Thanks so much for that, Ward, and lots of people reflecting in the chat on your comments and really appreciating those reflections as well. I do want to give, I'm conscious, and I knew this was going to happen, the time is running away on me. So we've only got a few minutes left, but I do want to give Wendy, you, and Deb, you too, a chance for a last reflection, a key takeaway. So Wendy, did you want to go and jump in?
Okay, thank you. I just want to make one comment pursuant to what Ward said, and that is, in our program, we're going to be recommending that the facilitator, the skilled facilitator mediator be a third party from outside the organization, and with some really predefined skills that would be required and some proven track record. So just so that you're aware, that's a perspective we're taking at this point in time. I think the message from this session has been incredibly strong, and to remember that mutual healing and the value of mutual healing, recognize it takes expertise, and it's got to occur in a psychologically safe situation and environment, expertly facilitated, as I mentioned, and integrated within the organization's existing processes that are in place if we really want therapeutic healing to occur. And also recognize not everyone's going to be ready, willing, and able. It takes the right time, the right place, the right people. But when it is set up, and as Deb said, if the foundation has been set from a communication standpoint and so on, the outcome can be extremely positive and healthy. Thank you.
Thanks so much, Wendy. Deb, last thoughts for today?
I think having the goal in mind at all times, and that's healing. Having that as the goal of all interactions in healthcare, and working towards that. I can't say enough about having champions, and I encourage everybody, challenge everybody here to be a champion for somebody. Be a champion to make it safer, to help somebody to healing. I had Sharon Nettleton, who's online, as the liaison into the Calgary Health Region. I had Marianne and Awana over at CPSI that were always there. We had Ward, people like Wendy and outside organizations as well. Finding champions is so important. And I just see Ryan has signed on here, and absolutely, when we worked together in creating Patients for Patient Safety Canada, it was a really difficult challenge at the time, because nobody had dealt with any of the emotions of all of this group of people coming together and we need to recognize this. This is an emotional issue for providers and family. So I was blessed to be connected with so many great people, and Jack Davis is my true champion because he had the guts to say, let's not hide this, let's talk about it.
Thanks so much, Deb. And with that, I need to thank absolutely everybody, absolutely our three panelists today, but also everyone who's been sharing and engaging in the chat with some incredibly powerful and important stories and comments to share. And just like disclosure is not a one-time event, as several of you said, this conversation also can't be a one-time event. So nobody's paying me to say this next bit, but if you haven't had a chance to pick up Fatal Solutions, the book, you definitely should. There's really, really powerful description that goes into also more about how do we actually move forward from here. And start, Deb, nobody's paying me to say this either, start by reading Deb's afterword, and then read the rest of the book. And Ward, thank you for that tip, because I did do that when I was picking up the book. So thank you for that. We also will be continuing this conversation. So Canadian Patient Safety Week coming up next month is focused on pressing play on safety conversations this year. So I invite you to join us for that, and that continuing opportunity to develop our collective muscle and skills and leadership for these types of conversations, and so many positive reflections coming in the chat as well. Your feedback can really help us to continue to improve these sessions. So we're bringing up a poll right now. If you have a second, just to give us some feedback on today's session to help us to coordinate for the future, that would be much appreciated. And once again, huge thank you to Deb, to Ward, to Wendy for your reflections today, for your generosity in sharing those reflections and experiences and learnings. And I look forward to continuing this work with you. But unfortunately, it does conclude today's event. So have a great day, everyone, and thanks again so much.